Alright, welcome to Neuro Clarity, where neurology becomes crystal clear. My name is Onowori Victor, and today we are going to be doing the Chink 10's comprehensive review of clinical neurology. We are currently in chapter 2, and we've done questions 1 to 19. We are going to be doing questions 20 to 21. We'll be diving into a classic but easily misinterpreted case, and this is going to help us to sharpen our localization skills and our stroke pattern recognition. That being said, let us begin. Question 20. A 49-year-old man presents with ataxia. His brain CT scan is shown in figure 2.4. Which of the following is the most likely artery involved? A. Anterior inferior cerebellar artery. B. Superior cerebellar artery. C. Posterior inferior cerebellar artery. D. Posterior cerebral artery. And E. Vertebral artery. Let's take a look at the CT. So, what do you think? Well, this case tells us that this man has ataxia. His brain CT shows a right-sided cerebellar infarct, but it's not just anywhere. It is located superiorly in the upper part of the cerebellar hemisphere. How do we know this? Spot the obvious thing in this CT. It's the Mickey Mouse at the center. You see a Mickey Mouse, you think of the midbrain. At the back of the midbrain is the cerebellum. In fact, the superior part of the cerebellum. Easy peasy, right? Let's walk through the vascular territories. The anterior inferior cerebellar artery or ICAR supplies the inferolateral pons, the middle cerebellar peduncles, and a ventral strip of the cerebellum. The posterior inferior cerebellar artery or PICA supplies the lateral medulla, the inferior cerebellum, and the inferior vermis. The vertebral artery can cause pica territory strokes but not strokes in the superior cerebellum. And the posterior cerebral artery or PCA mainly supplies the occipital lobe and thalamus and not the cerebellum at all. So, which artery is responsible for a superior cerebellar infarct? If you're thinking the superior cerebellar artery or SCA, you are absolutely right. The superior cerebellar artery supplies the superior half of the cerebellar hemisphere, the superior vermis, the superior cerebral peduncles, and parts of the upper lateral pons. In short, if the infarct is superior, think superior cerebellar artery. If it's inferior, think pica or ICA stroke. Simple patterns, powerful localization. So, with that being said, our answer is options B. Okay, so for question 21, we have a 42-year-old right-handed woman with diabetes and dilated cardiomyopathy who developed acute confusion. On examination, she does not follow commands and is speaking fluently and saying multiple phrases that do not make any sense. She seems to have a visual defect in the right hemifield. An MRI is obtained which shows evidence of a stroke. Where is the most likely vascular occlusion? A. Trunk of the left MCA prior to the bifurcation. B. Lenticular striated branches of the left MCA. C. Superior division of the left MCA. D. Inferior division of the left MCA. And E. Penetrating branches at the level of the pons. Now, let's take a pause and let's think about this case. Basically, you are asked to evaluate a 42-year-old right-handed woman who has a history of diabetes and dilated cardiomyopathy. We are told that she developed acute confusion. On examination, things are not just adding up. She's speaking fluently, but her words are nonsensical. She does not follow command, and you notice a visual defect affecting her right visual field. We are told that an MRI confirms that she has a stroke. Now it's time to localize. This presentation screams receptive aphasia, also known as Wernicke's aphasia. Key features include 1. Fluent but nonsensical speech. 2. Impaired comprehension. 3. Inability to follow commands. 4. Possible contralateral visual field deficit. So where's the lesion? A left MCA trunk occlusion would cause global aphasia plus dense hemiplegia. That's not what we are seeing in here. A lenticulostriate branch, in fact, will produce pure motor deficits with no language issues. A superior division MCA stroke will cause expressive aphasia. The speech would be non-fluent. And a pontine stroke does not cause aphasia at all. That leaves us with the inferior division of the left MCA. The inferior division of the left MCA supplies the posterior superior temporal gyrus, which is the key language comprehension center. Damage here will cause Wernicke's aphasia. Let's take a quick pause and a question. Wernicke's area is Brodmann's area. What? If you said Brodmann's area 22, you are absolutely correct. Now, because this inferior division also feeds cortical areas involved in visual processing, a contralateral visual field deficit like right hemianopia can also occur. Here's the takeaway. If your patient presents fluently but does not make any sense, can't understand or follow commands, always think left MCA inferior division stroke. The Wernicke's area is most likely affected. Simple localization, powerful clinical insight. Thanks for listening and staying tuned. This has been Neuroclarity, Clear Minds, Clearer Neurology. Thank you for learning with us and see you in the next episode. Stay clear, stay sharp. Bye for now.